All right, welcome back to the All In, All On X pod. I'm your host, Dr. Adam Hogan with the Atlantic Implant Institute and Full Implant Choice here. And I'm excited to bring you something a little different today. I wanted to give you a little education content, a little something to help in your full arch practice. So this is going to be a wonderful episode, a great episode about digital full arch dentistry and a technique that I developed that I amended from the previous full arch workflow. You're going to want to listen to this podcast and watch it on YouTube because I'm going to have a lot of screen content for you. And I'm really giving you an insight into my philosophy and how I do things on a daily basis at Full Implant Choice. And I'll be showing you how we teach things at the Atlantic Implant Institute. Welcome back to the All In, All On X podcast, where we take you behind the scenes of full arch dentistry, innovation, and the people who are redefining what's possible. Here we go beyond the procedures and into the lives of people shaping full arch dentistry. This isn't just about implants or workflows. It's about the lives we build, the decisions we make under pressure, and the leaders who push this profession forward when no one's watching. Get your head straight, because we're about to go all in. And, quick comment on that. We are currently enrolling now for Module 1 in August, Module 2 in September, and Module 3 in October, and all three parts are part of the Full Arch Continuum. And we have announced a new business course, October 23 and 24 in Houston, Texas. So stay tuned for that. More details on that as we go through here on this program. But get to YouTube because you don't want to miss this content. I'm going to be talking about mandibular full arch and digital alignment. So this is all through something that I developed. If you're looking at YouTube right now, you can see an image on our screen. This is an image. You'll see 3 fiducial markers, one in the anterior mandible. That's mine, my technique. And you'll see it perfectly under alignment. And you'll see 2 other scans superimposed on this image with fiducials in the posterior. This is, I would say, the initial way that this was taught and the way that a lot of people are still doing it, to put fiducial markers in the mandibular posterior. And you can see right away that we have alignment problems and that you cannot align the posterior mandible right with the posterior mandible left with the midline all in one foul swoop. So let me get into this without any further ado. Let me change screen. I'll tell you a little bit about the history of this. So I've been on digital workflow for, I don't know the start of this, 5-6 years now. And when I was originally shown how to do digital workflow in the mandible, we were told to place a fiducial in the mandibular posterior on each side. We were told place it on the behind number 18 and behind number 31. And right from the very first time I did this, I saw there were problems with that workflow. I mean, as I was being told, hey, put one of these pegs or 2 of these pegs in the 17 area, and then put 2 of these pegs in the 32 area, and then we'll scan the arch. And I was like, as soon as they told me to do that, I went, this is going to be a problem. I've got infected teeth back there. I've got soft bone. This is a case with a very shallow, very limited amount of bone to the mandibular canal. It's also very shallow mandible, very thin mandible. It's very thin to the submandibular fossa. So 3 problems with it already. And then I'm thinking 4, I'm going to want to do a distal oblique releasing incision in front of the retromolar pad. Now that's going to be in the way of my incision line. And then I won't be able to fully reflect the retromolar pad. So now it's a problem with alveoloplasty. And then I'm thinking of alignment problems, but I'm like, okay, let's just go with it. I mean, I got 6 reasons not to do it already before I even did it for the first time. And then I'm thinking of alignment problems. Why? Because I was my own digital lab tech for years, for 18 years before I at this point I had a lab tech in the office for 2 or 3, but I was my own digital lab tech for a long time. So I was thinking, right from the get-go, this is not going to work. I mean, this is going to be a problem. But let me show you. So I was not even into the workflow yet, right? I'm not even into the workflow yet. And I know that it's going to be a problem. Why? Because when you try to use an intraoral scanner and scan number 17 and you try to scan number 32, you're not going to have a line. You're not going to have, they're not going to align. They're not going to align every time. Sometimes they're going to align close. Sometimes they're going to align very far off. And it was no surprise to me on that very first surgery that here 5, 6 years ago, that the lab tech that worked in my building, that worked right across, right in the back, came to me in the surgery room and said, "Hey doc, I can only align the right or the left. Which one do you want me to align to?" And, obviously that's a problem. It's a guess. So I was like, pick the left. Okay, pick the right this time, pick the left that time, And sometimes they were, every now and then, over the course of a few months, she'd come to me and say, "Okay, they both aligned. Okay, great. We got a great scan. Technique, everything was good. Maybe there wasn't a lot of bleeding in the field. Maybe the tissue wasn't very mobile. Maybe the scanner worked better. Maybe we were just better lucky that day." But invariably, most of the time, it would simply not align. So I needed a solution. So fast forward. We meet some folks out west from Fresno, California, who have a long screw that they want you to screw into the alveolar ridge. All right. They want you to, let me go back to this picture that I'm sharing here. Let me go back to that because I can demonstrate there if you can see my cursor. So look at this image. They want you to put in that one fiducial. Maybe you put it in 17, maybe you put it in 31. Maybe you just decoronate, you cut off the crown of your first bicuspid or your canine. I think they typically recommended your canine. They would cut off the canine and just sink this into the root. And then you would have to perform, inconveniently, you would have to perform all on four surgery around the fiducial, being careful not to, it would stick up high into the work field. It would get in the way of your armamentarium and your drills. And they would tell you, okay, place your 4 implants, don't disturb the canine, don't disturb the fiducial. And after you get all the scanning done, you can then remove the fiducial and you can remove that last canine, and then you can finish your alveoloplasty. And it just, to me, it was messy. So this group came out to the Atlantic Implant Institute, and I was doing a live surgery. And I'm going to flip over to this image here. So I was doing a live surgery. While I was doing the surgery, this instructor, this doctor, this educator was out in the classroom talking. And we were getting ready for live surgery in the octagon at the Atlantic Implant Institute. And I put the screw in the chin where I had been placing it, I don't know, for months or a year or something. For a long time, I'd been putting this thing in the chin. I guess I just never told anybody. And he came in and he said, "Whoa, whoa, 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 you're doing this all wrong. It doesn't go there." I said, "No, that's exactly where it should go. That's the only place that it should go. Because when I put it in the midline and when I drop it down below the mandibular symphysis, it's going to be out of my way. It's going to be out of the way. I can do my surgery perfectly clean. I can remove all the teeth. I can place all the implants. I don't have to leave half a crown. I don't have to leave a canine. I don't have to have it in the way of my incision lines. It's going to be out of the way. And if I put it down in the mental symphysis, it's out of the way of my alveoloplasty completely. So I put that thing down in the chin, and he said, "No, you're doing it wrong." And then he washed and he said, "That's amazing." Now, flash forward, I understand a lot of people have been out there to their courses and they claim credit for this, but I actually have a video of them, of him saying, "Oh my God, it's in the wrong place." I'm not going to show it here. But anyway, this is something that I developed here at the Atlantic Implant Institute. And also, the other reason I did it, digital workflow. You can scan from the chin, you can scan back one side, you go back to the chin, scan the other side, and guess what? You've got better alignment because you're not going all the way across the arch and around the curvature. You're going just linearly, midline straight back, midline straight back. And the deviation in the posterior is far less than if you were to start on one side and go all the way around. And I'm going to show you some pictures and images here. By the way, this is a part of a bigger publication that my partners and I are publishing. I'll take credit for placing the fiducial in the midline. Some ideas I'm borrowing, for like the long bone screw, but I wanted to put this in the mandibular interior. Dr. Keith Klaus, my partner in crime, for prosthetic workflow module 2, which is in September, he said this would be even better with an MUA on it, which genius. Absolutely. We put a multi-unit abutment on the bone screw, and then you're able to put anything on the screw that you can place on a multi-unit abutment. So any cataloged stand body that is available for a multi-unit, you can put on there. So then, Keith and I have no interest in manufacturing and building stuff and undertaking that. So we went to our friend Danny Domingue, and um, Danny, said, "I'll be glad. I'll be happy. I'll be glad to produce this for you guys." So Danny um, manufactured for us the bone screw that goes in the chin and a multi-unit abutment. And then what's even better, we asked him. We said we need a scan body that we can time, that we can take on and off. So through Keith's efforts, my efforts, and Danny's efforts, we created this scan body. All right. It's got 2 flat sides. You screw it on. You can screw it onto the this bone screw. You can scan it. Then you can take it off so that it's completely out of your way. And so these are available over at Danny's LA Labs in Louisiana. And I'm not getting any royalties or any payment for this, neither is Keith, but we were just happy to be able to bring this to you. So, without further ado, let me share with you some of the workflow and show you why this has been absolutely tremendous. Let me get back into another screen. So we're going to be publishing this, Dr. Keith Klaus and I, and with the help of my partner here for photography, Dr. James Lish, and Dr. Danny Domingue. But I'm going to be publishing a case about this workflow and how it compares to the bilateral scanning technique. And let me get into that and show you a little something. Okay. So here we have a case. All right. This is a patient of mine, been in my practice for since the beginning, 24 years. And about 14, 15 years ago, I did his upper arch. This is an upper bridge. It is an implant level bridge, full arch restoration. Been there for 14, I think, going on 15 years. And he came to me needing to replace his bottom teeth. So this is what his upper bridge looked like when he came back. He had been absent from the practice, by the way, for a little while. And by the way, I have full permission to show these slides. He fully consented to being in a scientific paper and putting this out there for educational content. So this is his upper arch, all right? And it's about 14, 15 years old. You see there's some lost composite here, whatnot. He wasn't complaining about that. That can all readily be fixed. But everything's been real stable. Looking at his mandibular arch in the posterior, those are 2 of my implants, 19 and 30. And then he had fixed crown and bridge here, 19, 20. There's a bridge from 22 to 27, and I think crowns on 20 to 29. And now he's suffering from recurrent caries. So we're going to do digital workflow here. So this is where I start with my technique, this number 15 blade. I'm going to make an incision right in the central labial frenum down to the bone. I'm not going to carry this all the way up. I'm not going to disturb the mucogingival junction around the teeth. Then I'm going to take a drill, and I'm going to an osteotomy drill, something like a 1.4, 1.6, 1.8 drill, and I'm going to just make a hole right in the center of the mandible. Now, in my mind, I'm going below the mental trigone, below the top of the pyramid. That way it will be completely out of my way for alveoloplasty. And I'm angling this out at about a 30-degree angle, okay? It can't really be 90 degrees because it's going to be in the way of the teeth. You don't want it out, flat out too far. You want this upright, about as upright as you can. So it's close. Why? So the scan body is close to the teeth And you're going to get better accuracy when your intraoral scanner has a shorter distance, a shorter path to scan. So I make a hole, and then we've got the bone screw with the MUA on it. This is the AIM Fiducial. It's called AIM for Atlantic Implant Marker for the Atlantic Implant Institute. Again, made by Danny Domingue at LA Labs. And so we take this bone screw and we place it in, and this thing is going to be tight. It is going to be in there at 80 newtons easy. Careful over torquing it, just like you would be careful over torquing any implant. You don't want any fracture of bone, any, iatrogenic fracture of the mandible if you're dealing with a small mandible or anything like that. I mean, very low risk if you know what you're doing, but you have to be cognizant of that. So you're going to put that in there at about 80 newtons, but it goes in there really tight. And I'm telling you, I've done this on I don't know how many hundreds and hundreds of mandibles. And I mean, I've only encountered one or two soft mandibles that we actually had to worry about. But if you come to my digital workflow class, I'll show you a workaround on that. But that's like the 0.1%. So this goes in, this bone screw, and you see the MUA on top. And here it is from the occlusal view, trying to get it somewhat centered. I'll tell you in this case, I'm off center. It's okay. I'm off to the 25 area just a little bit, but it is what it is, but this worked just fine. And then we put our scan body on it. This is the Atlantic Implant marker, again, sold at LA Labs. I get no royalties from this whatsoever. But we put this fiducial on, and now we're ready to scan. We're ready to scan to the back left corner and then to the back right corner, and then we're ready to go. All right. But for the purposes of this experiment, I wanted to show you an in vivo study on if you do both techniques at the same time, what you get. So, and the patient knew we were going to do this, fully consented to do this at the beginning. So here we are using our osteotomy burr, and we're going into the number 18, 17 area, and we're just purchasing through the cortex, through the superior cortex. I'm not drilling this down for far into there. All right, so we do it on the right and left. And what you see here is you see a fiducial in the 32, and you see a fiducial in the 17, and we'll go back here. And you got one in the anterior. Okay, now this is not typically the way that I would do it. All right, in my patient, I would only have this screen you see right here, just one in the center. The other two, again, they're for scientific purposes for comparison. All right, so I got the one in the center. Now, for me, I just scan this, I save it, I take off that scan body, I start my extractions, my incision line extractions, alveoloplasty, and all that, and we just go. But here we are, we're placing it in 17, we place it in 32, we got our scan bodies on top, and then it's time to do both scans. So this putty here, impression material, you get a blue putty, green putty, purple putty, something that's easy to scan. It's just going to help your intraoral scanner. Intraoral scanning technology is not perfect. There are limitations of the technology, which is one reason that I'm not a huge believer in intraoral photogrammetry with intraoral scanners, because they're all handicapped. Some are better than others. Some are definitely better than others. We can get into that debate, but not today. All right. But, I like extraoral photogrammetry. Intraoral scanners, they're capable of what they're capable of, but they're very dependent on the scanner and the technique, who's scanning. And on that subject, on the subject of digital workflow, your scanner has to be amazing, but it also has to be user friendly. I often use the term lowest common denominator. If the lowest common denominator, the employee with the least amount of ability can't use it because it's too complicated in its workflow, then it's more or less worthless to me. I need everybody in my office to be able to use that technology. So intraoral scanners, we can get into that all day. We talk about that a lot in September, upcoming in September digital workflow class. We talk about the limitations of technology. So anyway, we've got all three in place. And what we did, we did a scan. I scanned, this is part of a bigger scientific paper that we're getting ready to publish, but we scanned the midline back, my technique, and then we scanned from 17 to 32, and then we took a scan from 32 to 17. And just to show you how poorly they all align. So here we are reflecting the flap, okay, and getting it out of there. And here I just broke off that anterior bridge so I could get a better incision line through the KG. We pull this back. Now here, I have a very particular method. See, you'll notice that my incision is not split down the midline. I very rarely have had a tear or had to cut that. I like to keep the keratinized gingiva intact, so I'll reflect the mentalis muscle very deliberately under the flap and then gently lift this flap over the bone screw. And it's one key is that we designed this so that this scan body that you see here can come off and go back on and be timed in the same position. So we lift this over top, and then we've got a nice band of keratinized tissue that's easy to approximate when we're finished. Excuse me. So where am I? Okay, so here we are. We lifted over top. All right, now I'm using XNav, by the way. I've been using XNav in my office for about a year. 23 years a freehand surgeon, have, but I'm not ashamed to bring in some technology where it makes everything better. By the way, quick on XNav, of course, it's got surgical benefits and placing implants perfectly, but the prosthetic benefits are enormous. Okay, increasing AP spread, improving access holes, improving angulation, thinning prostheses for better phonetic, et cetera, et cetera, et cetera. So anyway, that's an XNAP tracker arm. You can see what I've done is I've placed it in the chin. This is in the symphysis, in the mandibular symphysis. So the aim fiducial is below the top of the mental trigone, and then the tracker arm is below that. This is standard protocol that I do every day. Here it is from the front. Okay, so we got that aligned. Now here you see us going through our full arch surgery. We've got all the teeth out, and I've got the posterior implants in place. Now, if you had been doing this the old way, if you had fiducials in the posterior, you would have had difficulty with your incision lines, and you would have difficulty with your reflection of mucosa, and then you would have had difficulty completing your alveoloplasty to completion. And some of, or if you did this the way that it, was shown to me by that group out west, the fiducial would be in the canine, it would be completely in the way. I'd have a big, giant, elevated ledge of bone and a root there still to deal with, and that would get in my way of the tilt or the anterior implant. So you see that with my technique, everything is out of the way. All right. And the bone is level, it's planed. We've got 2 implants in place in the posterior, right? So we're showing you that the bone screw is not in the way. Okay. It's not in the way at all. All right. And then here we show it with the 2 implants in the anterior, right? So you can see it's not in the way. Now, I'm just a little off to the patient's right on this midline, but you can see it still is of no consequence. But if you're dead center, you're even more likely to be out of the way from 23 and 26. I have not had a situation where I couldn't place 20 or 30, 26. And again, through many hundreds of these arches. So there you go, very efficient. And then here, this is the benefit of not doing a midline incision and releasing that for the convenience of releasing the flap. I was very careful how we elevated this flap under the flap, down the mentalis muscle to remove it and lift it over. So here I'm able to just gently lift it back over top. And then you see we're able to refix the scan body, all right? That's in the same orientation that we had it in, right? So this is here we are showing back up. I'm a little out of order, but this is us showing photogrammetry. We're using Micron Mapper in the surgery room. So this is their newer scan bodies, the 2-piece scan bodies. So we are using Micron Mapper here, and we do that. And then we're ready to close. I've got my PRF ready to go on the table. And then let's go back to that soft tissue. So this is as we're getting ready for our intraoral scan. We lift the tissue over the bone screw. We place the scan body on the bone screw there itself. And then in the back on implants and MUAs number 20 and 29, I just place a healing permucosal healing collar. This is just going to sit there for about 2 or 3 hours while we print teeth. Then I'm going to place 2 catalog scan bodies on 23 and 26, right? 23 and 26. And then we're going to get ready to close. So now with the tissue open, I know that everything is fully seated. Now I'm going to close the tissue. So I got my PRF, going to lay it over the ribbons between the implants. So a little technique I often like to do. We're going to get it all closed up. Looking pretty good here. I like things to be, closed but relatively loose because I want the intaglio of the prosthesis to press in there and form a hygienic contours. I want the prosthesis itself to dictate. Talking a little bit about that, this is where you're ready to do your scan, your alignment scan, your fiducial scan. A lot of people will call this the soft tissue scan, the tissue scan, right? Now, tissue scan is one benefit, is one aspect of one goal of what you're trying to capture. You're trying to show the digital technician roughly how thick is the tissue. Okay, why? So that they can approximate how much pressure to put on it. The problem with calling it a tissue scan is a lot of lab technicians who are doing their best, but they're not doctors and they don't really understand the full aspect, the full gamut of ramifications of that term. They will adapt the bridge to the tissue. And that's the last thing you want to do. You're just using the tissue as a guide roughly for how much pressure do I put on that tissue. So this is not, in my mind, a tissue scan. This is an alignment scan. And you'll notice there are only three pieces that can be aligned here. My midline fiducial and whatever you're putting on 23 and 26. And I believe these are DES 018 scan bodies. If I remember correctly, I've been using these things since I started with digital workflow. I still have this, same ones in the office. We've been using them for years. They're 018s, and I use them because they're tall. They can get over top of thick tissue. They scan very well and they give us excellent results. Now, the only thing that I need to get a good, clean picture of is these three pieces right in very close proximity to each other. So what am I doing? I know intraoral scanners have a limitation of their technology, somewhat limited to the size of the field that they can capture. So in a very small area, I can capture the midline fiducial 23 and 26 in just a few views. I mean, 50 views, 100 views tops, and you don't have to move the camera very far to get all three scan bodies. And that gives us perfect alignment every time. So I don't care about what's on 20. People always say, well, are the premucosal, the abutments on 2029, are they cataloged? Can you align to them? I mean, technically, yes, but they're 3D printed, so they're not going to be totally accurate. But also, if you ever took an exocad class or watched your lab tech work, they cannot perfectly align number 20, number 23, number 26, and number 29. They will never perfectly align. So I just go straight to the midline. And I've been doing this for years and years and years. I just thought everybody would be doing it. It's, a year ago. I've been doing it for years, talking about it for years, 3 years, 4 years. And I learned that people still don't do it. Just in my last digital workflow class in March, I was talking about this with Dr. Keith Klaus, and there was a doctor, a delegate, a practitioner in the class, and he said that he had just come from another class a few months ago, and they said, never put the fiducial in the midline because you can get a life-threatening bleeding risk. I said, where did you hear that? I said, never mind. I don't want to know. He did not tell me where he went. I said, let's talk about this for a second. The mental symphysis, the chin. Okay, what's beneath there? Mostly dense bone for a good long bit, like a centimeter or more. Genioglossus artery, very deep, lingual, right? Where do we take chin grafts, by the way? We take chin grafts from the chin, the mental symphysis. So when I take a chin graft, a block of bone to go to the posterior mandible or to go up to the maxilla, we're cutting off a thick piece of bone that's 6 or 8 millimeters thick, and it's a centimeter wide, and we're moving that up there. I'm talking about just taking a pilot drill and puncturing through the buccal cortex and not drilling in more than about 6 millimeters, and then just putting your screw in. And I'll be the first to say that you should make your own clinical decisions and do whatever is in your own comfort zone. But the little genioglossus artery, go look at your CT scans, go look at your CBCTs, look at how deep it is. Ask yourself, if I were to puncture the buccal cortex 4 millimeters, 6 millimeters, is there a high likelihood of risk? I mean, some of you guys, people that would say that, are doing pterygoid implants, and you've got a much bigger bleeding risk in the posterior there in the pterygoid region, or even in the mandible for that matter. I'd argue that if you're placing these fiducials in 18 or 31, you've got a much bigger anatomical risk. You might be millimeters over the mandibular canal or just millimeters over the submandibular fossa. And so, and the bone back there is not very good quality either, by the way. You're going to put a fiducial in 17 or 32. I was doing that for, I don't know, some months when I was first taught digital workflow before I went to this, before I developed this technique. And you got a very thin cortex and the rest of the screw is in D4 medullary cancellous space, and you find that that screw is moving. So anyway, enough on the comparison, but this has proven true for me. Here we're showing, you can see them in the back. Again, this was just for our experiment, our little in vivo experiment. We did scans in all three directions from midline back. We did them from 17 around. We did them from 32 around. So that's what this all looks like. I'm going to save the results, most of the results of that study, but let me, so here we are. We did our intraoral scanning, so I can just put these two healing caps on 23 and 26, and we will be ready to, wake up the patient, and we'll be ready to finish the surgery. So let me share with you a couple of other screens. So let's go back to this, right? So I started off with this, all right? This is where we overlaid all three scans, okay? Now on this particular scan, this is where we overlaid the midline on top of itself. When you scan it, we scanned each one 3 times. And when we scan the midline, look at all the blue. The blue shows a good mesh. So 3 scans over top of each other. In this case, this image is just 2 of the 3 scans. 2 scans over top of each other with good alignment on both. What is that going to tell you? That's going to tell you that you're going to create a first provisional that has excellent alignment, midline, cant, plane of occlusion, all that. You're able to design in such a way with high confidence that you're going to get a good result. Now, contrast that with what you see in the back in there too. You see diplopia, you see double vision, you see 2 different scan bodies. In this case, they're particularly very divergent. Now, for all those people who have said there's no such thing as cross arch deviation, look at this scan. This one is egregious. This is terrible. But even when they're very minor, they're deviant. They are off. Not like the midline you see here. I was my own designer from 2011, 12 to 18 before I hired a designer. I know the limitations of intraoral scanning. At best you get 50 microns of deviation. And oftentimes you get 400, 500, 600 microns. Depends on the camera, depends on the technique, depends on the mobile tissue, the amount of blood, all that. The technique being probably the most important, and the camera. All right, so there are many reasons why this midline fiducial technique that we developed at the Atlantic Implant Institute is the way to go. So let me see if I can find. So we did the surgery. And then real quick, I'm going to hold off on this real quick. I want to share with you what's upcoming at the Institute. We are currently filling slots for August 6 through 9 for the basic boot camp module 1. Brandon Coford from Smart on X is going to be there with me. Dr. Athena Godarzi from 4M Institute. She's their co-faculty as well. And we're going to be teaching that August 6 through 9. We only allow 16 seats in these classes to be filled by new doctors. So space is limited. If you're interested, come on in. After that, prosthetic and digital workflow with Keith Klaus, the co-inventor of this technique with me, September 17th through 19th. By the way, on the 20th, he'll be doing an exocad full arch boot camp. You don't want to miss that. Even if you're not a designer, you need to understand what goes into exocad and what your designer looks for. It'll make you a better prosthodontist and a better surgeon. It'll make you a better dentist. So you want to sign up for that as well. Oh, there's the exocad boot camp. And then skipping ahead a little bit, I just announced a business class for October 23rd and 24th in Houston, Texas. And I just ran this business course. It's $20,000. After the first hour last month, one of the participants said he would pay 50, and after 2 days, he would have said he would have paid 100,000 for it. I'm going to teach you how to 5, 10, 20. do 20 arches a month per doctor. I'll teach you how to take your practice into millions. You don't want to miss this. Space is limited on this one as well. But getting back to the clinical stuff, Module 3 is in October. We just finished this course this weekend at the Atlantic Implant Institute. This is Dr. Wynn, Dr. Jarek. We're talking subperiosteal implants. We're talking remote anchorage. We're talking zygos, pterygoids, transsinus, palatal, transnasal, all that. Live surgery with cadavers, with hands-on. So, and same goes for in August. So, I just wanted to have a minute to share that with you. But I want to share now the results of that procedure. First set of teeth. Okay, mind you, the beauty of this study is that it's controlled to the mandible. I picked this case on purpose because the maxilla was fixed and the patient was 14 plus years happy with the results. No cosmetic changes. The maxilla doesn't want any, not undertaking that task. We're just doing the mandible only. So it's a good controlled study. And this is our first provisional that we put in. Take a look at it. No adjustments, right? Just showing you, the height, relative height here, about 15, 16, 17 millimeters. Looks good. Looking good there, nice and even. Here we are on the occlusal, the intaglio. Tell you a little comment about these access holes. I think they're great. I think if I had control of the upper, you would have seen the upper teeth probably extrude in the anterior, probably open the vertical just a little bit, probably would have moved 23 and 26 a little bit further forward, but still excellent result. If you don't understand those prosthetic concepts, what I just said, look at our September class where we talk all about vertical and convolution yard. But here it is from the front, 3D print. All right, maximum intercuspation, everything feeling great. Okay, so there we have it. So that is our first revision. Let's see. I mean, revision. That's our first set of teeth. And so the revision, by the way, that's a dirty word in my practice because revision is basically a 4-letter word that means losing money. Okay, you're losing money, and you're probably losing your wits end. You're just going crazy trying to make uni teeth. Let's look at where we started. Okay, so here's his pre-op CBCT. All right, this is as he presented with crown and bridge on the bottom and 2 single implants in the back. Here we are. You see the implant number 19. All right, that's his preoperative pano. All right, so you see the upper all-on 5 implant level, about 14 years old, and the lower implants 19 and 30. All right, here I'm taking some bone measurements. By the way, I've got some very hardcore mathematical concepts on proper smile line and prosthetic planning that I'm going to save that for another day. And if you want to hear that in detail, come to prosthetic workflow in September. But so there we are with that. Let me look at his post-operative scans. All right. So we got our all on 4. All right. That's the upper is 14 years old. So here's our all on 4. Of course, the print is invisible. So we're not seeing it in the CBCT. It's not radio opaque, this particular print resin. But looking here, you can see my cursor. You can see we were probably right about here on the bone screw. All right. Right about there. Probably in that hole right there. And then the tracker arm was below that. So you see how we were able to plane the bone very nicely without interrupting our workflow. There we see it from the lateral, left lateral, and right lateral. Okay. Take a look at the implant placements. All right. Go through. Looks like that's the tilt number 20, probably in the anterior. Looks like number 26. I'll blow that up for you. Looks like this would be probably number 20. I think it was still in the interior there. So you get to see everything turned out really, really well. So that's it. That's our workflow for the mandibular fiducial. I'm very proud to bring this to you. I guess I bring it to you in this way because I'm a very humble guy. I don't like to boast or brag, but I've been hearing that other people are taking credit for this. And that just kind of bothered me a little bit, to hear that, when we in fact took credit, or we in fact did this, but I was happy to bring it to the community. This technique will give you much better alignment with all of your cases. Um, our mandibles, I mean, they are generally dead on. You don't get when that bone screw in the mandibular interior, you just don't get movement on that bone. It just doesn't happen. It it just stays perfectly still. And so mandibles are always on. In the maxilla is where we'll do another episode on maxilla later, but sometimes with the maxilla, with all the work that has to go into reflection for pterygoids and zygos and very thin palatine bones. With the maxilla, it's possible sometimes to get like a 5 degree, 3 degree cant in your fiducial alignments. And that's if you come to our September workflow class. If you come to our digital workflow class in September, we can show you how that can be corrected and fixed in 60 minutes, right? So it's super easy. Just look at this class, September 17th and 19th. But that's the beauty of digital workflow. If you do an analog denture and you snap it in and you wake the patient up and it's too far forward, or the midline's off, or it's canted or rotated or something, or it's open by the left side, you've got nothing. You've got nothing. You have to do another analog pickup, or you got to go, do articulators and remounts and all this stuff. So with digital workflow, I can show you how to, in 10 minutes of chair time, get something to the laboratory that as fast as you can print, you can get the correction back, and then you can be done with that case design-wise forever. You're just letting implants heal and then go into final zirconia. So very simple. Very happy to bring this to the community, and share this. So I want to go back, one last ask. Look at August. This is the first class of our continuum. Only 16 seats per course. August 6th through the 9th for Module 1, September 17th through 19th for Module 2, September 20th for ExoCAD. And then you've got remote Anchorage, October 9 to 11 with Dr. Wynn and Jarrett. And I will say business principles in Houston, very limited attendance. You're going to want to sign up now. You want to bring your team members and probably your spouse who help you make financial decisions, the people who are going to be there for long range vision and planning of your business. Also, you're going to want to bring your sales team or your treatment coordinators so that they know better on how to present cases and how to get people to say yes. All right. But one thing about business, I'm a business guy. I love clinical dentistry, but business is just a passion of mine ever since the days of playing Monopoly every night as a kid. But just, I love business. This is not just how much do you spend and where do you market. Of course, we're going to get to that. Of course, we're going to get to consults, lead management, how to get people to say yes. But we're also going to talk about some things that you should have in place before you do any of that, which is teams, systems, how you do handle production, what kind of systems you need to be efficient. Because if you don't have systems and the right team in place, then spending money for marketing is just a complete waste of time. So I really will take you through the A to Z on the business in those 2 days, and we're going to have a great time there in Houston. All right, so thank you for listening. I'm going to wrap this up. It's been fun sharing this technique with you. Those of you that have been to our courses for the past 3 years, you already know it, but this technique will allow you to get better alignment, safer and faster than the bilateral technique. And yeah, safer, faster, better. I mean, I'm going to sign up for that every day. All right, look for this publication. We're working on this now, and working on our second revision. We're going to get this out in the journals, and you're going to be able to see exactly how these scans compare from midline to posterior, and then right to left and left to right. All right. For now, that's it. I'll remind you that if you are going to be all on X, you've got to go all in. All right. It's a difficult field, but once you're fully trained and you see it, you understand it's like seeing the matrix, all the X's, all the O's, all the ones, all the zeros. And it becomes a lot of fun when you understand it. And we can help you do it better and stay out of trouble. So until next time, folks, have a great day. and I'll see you next week.
This episode of the All In All NX Pod is powered by JB Dental Lab, your full arch lab partner for predictable, beautiful, and digitally precise results. From provisional same-day conversions to final zirconia, JB delivers consistency, communication, and craftsmanship that elevate your practice. The proprietary case portal keeps your team connected with quick communication and real-time updates, while their in-house designers and comprehensive full arch services ensure precision from conversion to final zirconia. If you're looking to grow your skills, JB's Educational Center hosts hands-on courses with live surgeries. Ready to streamline your All NX workflow with a lab that truly understands the surgical and prosthetic connection? Visit jbdentallab.com and tell them the All In All NX Pod sent you. Thanks for listening.